Thank you. So after this emotional discussion, I will focus on another controversial issue, which is recertification for sudden cardiac death in patients with hypertrophic cardiomyopathy. And in an attempt to provide an overline and a comprehensive overview of this topic, I will begin by discussing the actual risk of sudden cardiac death in patients with hypertrophic cardiomyopathy. Then we'll proceed with discussing some observation on what data is known regarding risk factors for sudden cardiac death in this population. Then we'll provide an overview of the current guidelines considering those limitations, and we'll further focus on the gaps in knowledge and limitation of recertification, especially for primary ICD therapy in this population. First of all, it should be noted that only a minority of clinical recognized patients with hypertrophic cardiomyopathy will ever experience sudden cardiac death. Therefore, the majority have a similar lifetime expectancy and will not experience a life-threatening cardiac event during their lifetime. And second, up until now, medications, any type of medications, were not shown to reduce the risk of arrhythmic events in these populations, and therefore, ICDs offer the only effective means of preventing sudden cardiac death in patients with hypertrophic cardiomyopathy. However, the appropriate recertification and selection of patients for primary ICD therapy is currently very limited. First of all, there's variable definition for risk markers. For example, sudden cardiac death was defined in some studies as occurring in a 1 first-degree family member, and in some other studies as 2 or more. In addition, the relative infrequency of hypertrophic cardiomyopathy, only 1 in 500, and the even rarer occurrence of sudden cardiac death, make it very difficult to create appropriately conducted studies, even observational ones. And therefore, there are sparse clinical data regarding recertification in this population. Another important thing that should be mentioned is the morbidity associated with ICD implantation, specifically in young patients with hypertrophic cardiomyopathy, including a very high risk of inappropriate therapies and peri-procedural complications. It should also be noted that most studies that used and even attempted to re-stratify patients use a surrogate marker of appropriate ICD therapies, and this is not actually equivalent to the risk of sudden cardiac death. We have a large registry in the US of patients with hypertrophic cardiomyopathy who use the wearable defibrillator, in which they are able to use a response button to prevent the device from firing. And in a large proportion of them, they had sustained VTs, which was self-terminating and not really equivalent to sudden cardiac death. However, when you program an ICD to a low-rate cutoff, the device can fire, but it's not really equivalent to sudden cardiac death. Furthermore, guidelines do not consider the fact that the risk of sudden cardiac death is significantly attenuated in the older age group. So let's see what data we have regarding risk markers for sudden cardiac death in patients with hypertrophic cardiomyopathy. First of all, guidelines indicate a class 1 recommendation, and for this there is a consensus for patients for secondary prevention in patients who have had a history of VTVF, for those who have had sustained VTs, and for patients who experience sudden cardiac death. And we see that the risk of subsequent ICD firing in patients who have had implanted devices for secondary prevention was relatively high, 20% during the first year and 10 years thereafter. But again, this is ICD firing, and some of these VTs could have been self-terminating. So the actual risk of sudden cardiac death, even in secondary prevention patients, is substantially lower. A family history of sudden cardiac death is also considered to be a major risk marker. But first of all, as I mentioned, there's a variable definition for this marker. And second, there are many conflicting data. As we see, there was one study that did not show any difference in the risk of sudden death between patients who had a family history and those who did not. And the largest study that did identify a difference only showed this together with a history of syncope in a specific patient. This was not really stressed, but patients who never had syncope but did have a family history did not have a significant increase in the risk of sudden cardiac death during follow-up. So only a family history together with syncope was actually shown to be associated with a significant increase in the risk. Syncope was also suggested to be an important risk marker, but also, specifically in HCM patient, it has a multifactorial etiology. It could be vasovagal or neocardiogenic, and therefore requires careful clinical history. Furthermore, the predominant risk associated with syncope was only shown for those that occurred recently, within 6 months. And as we see in this figure, patients who had syncope within the past 6 months experienced a significantly higher rate of sudden cardiac death compared with patients who had no syncope or those who had more remote syncope, who were actually at the lowest risk. Therefore, it should be remembered that only recent syncope is an important risk marker, according to current data. Non-sustained VTs were also suggested to be associated with increased risk. And again, 5 studies that assessed this marker showed very conflicting data, and one study even showed that the risk is majorly age-dependent, showing that only in patients younger than 30 years of age, the risk associated with multiple and frequent non-sustained VTs is significant, whereas in older patients, this risk marker was not actually associated with a significant increase in the risk. Left ventricular wall thickness was arbitrarily defined as equal to or greater than 30 millimeters in most studies. But again, when it was actually evaluated in more comprehensive analysis, the risk was shown to be linear and again age-dependent. So we see, again, that only among patients younger than 30 years of age, increased left ventricular wall thickness was shown to be an independent predictor, and again in a linear fashion. Therefore, in a young person, for example, who is 20 years old and has a maximum wall thickness of 28 or 25, should not be considered to be at the low risk and not eligible for an ICD. And the same goes for the elder patient, but in the opposite direction. Blood pressure response is defined as effort-induced failure to increase by at least 20 millimeters of mercury or a drop of at least 20 millimeters. However, this marker that was suggested also to be associated with an increase in the risk occurs very commonly in up to 1/3 of HCM patients. And in addition, most of the studies that evaluate this marker only show the univariate association that was not significantly associated after multivariate adjustment for additional markers such as syncope or left ventricular wall thickness. Additional possible risk modifiers have also been suggested. One of them is left ventricular outlet obstruction, which is defined in most studies as equal to or greater than 30. Furthermore, there are some studies that suggested that there is a low risk of sudden cardiac death following relief of left ventricular outlet obstruction following surgical myectomy. However, again, this time there was also conflicting data on the topic. Furthermore, the dynamic obstruction limits this as a comprehensive risk variable in this population. As mentioned earlier, late gadolinium enhancement was also suggested to be a risk marker. This represents fibrosis or scarring of the tissue, and there are some limited data suggesting an association with sudden cardiac death. But again, as discussed earlier, it is very common in patients with hypertrophic cardiomyopathy, and in addition, there is lack of consensus regarding the appropriate imaging protocol or even a threshold. And as we see, there is a continuous and graded risk associated with left gadolinium enhancement in these patients. Therefore, there's no really actual established threshold for this marker for sudden cardiac death. 2% of HCM patients develop thin-walled left ventricular apical aneurysm, which has been suggested to be associated with scarring and subsequent sudden cardiac death. However, most of the risk associated with this marker is regarding heart failure and possibly some risk associated with arrhythmic mortality. And finally, genetic markers were also suggested to be associated with an increase in the risk. However, currently, routine mutational screening offers little prognostic information and is even a class 3 in current guidelines, since some mutations which are in the past considered to be malignant were shown to be associated with a significant increase in the risk of clinical marker, and the other way around. Some mutations was previously considered to be benign had a relatively high frequency of clinical markers. Furthermore, many of the mutations are relatively novel within specific families, and therefore, routine mutational screening does not offer important prognostic information. Let's summarize the information we have. First of all, all of the risk markers have relatively low predictive value in the range of 10 to 20%, And this is also only with regard to ventricular tachyarrhythmias. The actual positive predictive value for sudden cardiac death is even substantially lower. However, they have a relatively high negative predictive value, suggesting that if a patient does not have one or more of the markers, this patient is not really at actual increase in the risk for sudden death. Furthermore, the majority of the patients who will have one or more of the risk factors will never experience sudden cardiac death, and the cumulative number of risk factors was never shown to be associated with a proportional increase in the risk. Therefore, the risks appear to be the same for a patient who has one marker and those who have two or more markers. So considering these limitations and current data, let's see how guidelines summarize this information. Current guidelines provide a Class 1 recommendation for secondary prevention with an ICD in patients who experience prior body cardiac arrest or sustained VTs. In this patient, ICD is recommended. In patients who do not have those markers, additional major risk markers considered by the guidelines are a family history of sudden death in a first-degree relative, or left ventricular wall thickness equal to or greater than 30, or recent unexplained syncope. But as mentioned earlier, a family history was only shown in some studies to be associated with increase in the risk when occurred together with syncope. Furthermore, left ventricular wall thickness can be associated with increase in the risk only in young individuals, and therefore this cutoff appears to be arbitrary. Nevertheless, patients who have one or more of those factors have a Class 2A indication for primary ICD therapy. In patients who do not have those risk factors, other markers could be non-sustained VTs or abnormal blood pressure response to exercise. And again, if a patient has one of those markers, additional risk modifiers should be looked for, like leg gadolinium enhancement or LVOT obstruction. If a patient has a risk modifier plus one of those markers, this patient, again, is considered to be Class 2A indication, according to the guidelines. Again, it's expert opinion. And if a patient does not have one of the additional risk modifiers, this is a Class 2B indication. Again, this is not really, as we've shown, based on really clinical randomized studies or major studies, but only sub-analysis of the observational studies that I showed. And lastly, in a patient who does not have one of those markers, there's a Class 3 indication for primary ICD therapy. So in conclusion, current data suggest that even regarding established, even guidelines-based risk markers for sudden cardiac death, data are actually limited and conflicting. Therefore, in a specific individual, a decision regarding ICD implantation needs to be individualized. Considering the guidelines, we should also consider the patient's age, the strength that we have seen for each risk marker, and the risk-benefit of implanting ICD in a young individual, considering again the relatively high frequency of inappropriate therapies and peri-procedural complications. And finally, what we see is that there is a need for contemporary risk stratification approach in HCM patients that can further clarify this issue. Thank you.
Thank you very much for a remarkable review of a very difficult subject. I just would like to make one very short comment saying that the HA guideline or position paper is completely based on expert opinion. Unfortunately, we don't have randomized trials, as you well know, and it's not, their ideas are not even supported, as you showed, by data from the literature in current clinical data. The second point I would like really to add is that, to all this you said actually, but I would like only to add that there is now a first publication as an abstract at the ESC meeting was published by the London group of Elliott and McKenna, that they did reanalysis adding left atrial size and age to their algorithm, and this increased the ROC curve, and the area under the ROC curve in their prediction in another center in Bologna, patients with hypertrophic cardiomyopathy from 0.6 using the old algorithm of risk factors you just shown, when adding these two parameters, it increased to 0.8, and we are waiting for the publication of this paper. And thank you very much for participating. We have been told that we cannot go over time, so we are sorry that we cannot take any more questions. And thank you for our friends and colleagues from France for being